And good morning, good afternoon, or good evening, depending on where you are coming from. My name is Heather Cianci, and I will be your moderator and one of your presenters today for Freezing in Parkinson's Disease, Tricky, Sticky Situations. I'm not cold, but my feet want to stick and my words won't come out. We are very excited to have you here with us today to learn more about the wonderful treatment practice of LSVT Big and LSVT Loud. Before we get started with today's presentation, I do want to draw your attention to the bottom of the screen and really acknowledge that we really appreciate the funding support and couldn't do what we do without the funding support that we have been provided for from the National Institutes of Health, the Michael J. Fox Foundation, the Parkinson's Alliance, and the Davis Phinney Foundation. We'll go over briefly now the plan for the webinar. We will talk logistics in just a moment. I will introduce myself a bit further, as well as my colleague, Heather Hodges. And then as we move into the bulk of our presentation, we'll spend some time really discussing freezing as it pertains not only to gait, which a lot of people think about it with, but also to other movements and to speech as well. And then we'll focus our time on how LSVT Big and LSVT Loud can both help with this. We will then end with a question and answer session, and I will talk you through a little bit about how we do those questions. Now, in terms of logistics for right now, everyone in the audience is automatically muted so that we don't have any distractions or background noises from the various environments that you are joining us from. But please know that at the end of the webinar, there is the option for typing in questions. So the most popular way is to just type a question into the question box on your control panel. I will then go ahead and read that question out loud to the audience, and then myself or Heather will take care of that question for you. Now, if you would prefer to actually be heard, you can actually raise your hand by clicking on the hand icon on your control panel. I'll see that you have a question. I'll unmute your microphone, call out your first and last name, and let you know that your microphone has been unmuted. And you can then ask your question to the entire audience, and one of the presenters will respond. If we do run out of time today and you have further questions, we also have the option for you to email us at any time with your questions. So let me just take a moment here and briefly introduce our Heathers who are joining us today. So I am Heather Cianci. I am a physical therapist by training, and I am coming to you from Philadelphia, Pennsylvania, where I work at the Dan Aaron Parkinson's Rehabilitation Center, which is a part of Good Shepherd Penn Partners at Pennsylvania Hospital. I have spent the bulk of my career in working with individuals with Parkinson's disease and other movement disorders, and I'm really excited to spend time with you today, giving you a little bit more of insight into how the LSVT Big program can help you with this. My partner and co-presenter today is Ms. Heather Hodges, and Heather received her speech, language, and hearing sciences degree from the University of Colorado, and that's where she first began working with Dr. Lorraine Ramig's research team. Dr. Lorraine Ramig is the founder and inventor of the LSVT Loud program. Heather now works at the National Center for Voice and Speech as an ASHA certified speech language pathologist, as well as being a research associate. Heather is also Loud certified and works for the National Jewish Health Center in Denver, Colorado, treating a variety of speech, language, and swallowing disorders in both the adult and pediatric population. And both of us are very excited to have you here today and share our knowledge. So we do need to let you know some disclosures that all of the faculty members do have financial and non-financial relationships with the organization, and our non-financial relationship includes a preference for using both LSVT Loud and LSVT Big as treatment options. Myself and Heather Hodges are consultants, and we do receive lecture honorariums and travel reimbursements from the organization. One last thing before we start, we want to let you know that all of the clients who you will be seeing in the videos today have given their consult for this for educational purposes only, and any copying of these videos or viewing outside of the course is strictly prohibited. So please don't pick up your phone and videotape what you're seeing here today. The patients have only consented for this video under our auspices of care. So our learning objectives today is that we really hope that after going through this entire webinar today, that you're going to be able to identify the common triggers of freezing of gait, as well as triggers of freezing of speech and freezing of activities of daily living. We want you to be aware of how both LSVT Big and LSVT Loud treatments really can be tailored to your needs to treat whatever specific freezing issues you are having. And then also, just as importantly, we want you to understand the role of sensory calibration when we are using LSVT Big and LSVT Loud in treating these freezing issues. And both myself and Heather will speak more about what we're talking about with sensory calibration. So what are we talking about when we're talking about actually freezing in PD? What is freezing? Well, it is the sudden episode of the inability to move. So you go to start a movement and you can't even get it to start. Or you're trying to get that movement to go, and instead you're getting very quick, short movements that don't lead to your desired movement. So maybe you're standing from a chair and you go to take that first step, and either you are completely frozen where you can't move your foot, or you keep trying to lift the leg and it almost moves in kind of a tremulous pattern where you just keep trying to lift it over and over again and it doesn't move. Now, freezing also takes different aspects of its presentation, not only with the gait, but also with freezing with activities of daily living, where someone will go to reach perhaps for something and isn't able to pick it up fully. And Heather will talk a little bit more about freezing, how it actually makes speech stop or can produce changes in someone's speech pattern. Unfortunately, when we're talking about freezing with freezing of gait, it is frequently the cause of falls and related injuries. And it's most likely to occur in the later stages of the disease and during your medication off times. So generally, we're not seeing a lot of the freezing in the early stages in newly diagnosed people. But the longer the presentation of the disease process, the more likely we are to see these things start to become problematic. Now, what is it that causes freezing in Parkinson's disease? And unfortunately, we don't really know. It's not completely understood. Now, we see it as a movement problem because that's what we see. We see that we're not able to form the words, we're not able to take that step, we're not able to lift that bottle of soda. But really, it likely comes from executive functioning problems and attentional issues. So when I use the term executive functioning, I'm talking about our ability within our brain to acknowledge that there's something wrong, think about what's wrong, come up with a new plan for how to correct it, set forth that plan, and then kind of evaluate it and see if it worked. And if it didn't work, then try something new. And we know that individuals with Parkinson's disease have a difficult time with that, as well as attention and the ability to shift your attention from one task to another. You may notice that people with Parkinson's have difficulty with doing multiple tasks at one time. And then also that's compounded further by visual spatial difficulties, where all of the information that should be coming in through our eyes and through into our brains and interpreted really isn't making it to where it needs to go, and it's being misinterpreted. Now, these problems with executive functioning and perceptual deficits, while they're associated with freezing of gait, we also know that by looking at scans of the brain, that it also corresponds with certain parts of the brain actually having atrophy or some sort of damage. So we know that there is actually a problem with those parts of the brain. And the parts that we tend to see them on those scans are the frontal and parietal cortexes. So where does this freezing occur when we're talking about someone who is having freezing with regard to gait or activities of daily living? We are going to see it, like I said before, more commonly in the later stages of the disease and during the off times, but very frequently with turning. So if you are standing at a sink and you're washing your hands and then you need to turn to the side to get a towel, your feet might get tangled underneath of you. Or you are walking with your rolling walker and you're trying to make a turn, but the walker keeps going and you feel like you're not moving. So any kind of directional changes. I mentioned earlier the dual tasking. So if you're trying to carry something while you're walking, or you're having a conversation, or someone calls your name, many people will tell us about how when they're in a crowd or in a tight, small space, they feel like they can't make those big steps, and they feel like their steps just get jumbled together into those small, tight steps, and then ultimately into that freezing episode. Now, there is a category of patients who suffer from something called anticipatory freezing of gait, where if they know that there's a certain area of the house that they freeze in, they start to become panicked or anxious about that and think, you know what, I froze here before, I'm probably going to freeze again. I really need to be careful with what I'm doing, I'm probably going to freeze. And then that anxiety actually brings out the freeze. So in that kind of situation, people are less likely to be able to control themselves with the walking. So when they're actually being rushed, so rushing to answer the phone, rushing to get to the door, rushing to get to the bathroom, or if someone is telling them, come on, hurry up, we've got to get moving, that can provoke an episode of freezing. As well as with fatigue, we know that none of us are at our best with fatigue, but that individuals with Parkinson's disease really do suffer with fatigue issues greater than the average person, and we know that there is a host of problems with the sleep disorders with this. So we know where it occurs. We have an idea of kind of the changes of the brain, but what does it look like? What is going on? What signals are not going where they need to go? And then how are we seeing that? So the first one that I'm going to mention here is the get ready signal. That get ready signal is too weak. And that means that that person with Parkinson's is not really being prepared or hasn't properly set up their body to start the movement correctly. So that would be the example of someone who isn't leaning forward enough when they're moving from standing. So moving to standing, I'm sorry. So you may have experienced this yourself where you try to stand up from the chair and then you continually flop back into the chair and it takes you a couple of tries to stand up. And that could be just from simply not getting that propulsion of movement forward and not getting the correct setup before you need to actually make the movement. Now then we have the go signal. So the get ready signal gets us set up for what we need to do, but then that go signal gets us to actually execute the movement. So that is where the individual with Parkinson's doesn't choose the correct movement or actually isn't able to start the movement correctly. So we see this very commonly with individuals who go from being in a seated position for a while, go ahead and stand up, and then really can't take that first step. Or if they try to take that first step, the leg is just trembling in place. And then further on, we see difficulties with weakness in the no-go signal. And that means when someone doesn't have the ability to complete a movement or to actually stop a movement. And there's lots of different ways that you might see this. You may have heard the term festination, and that's with the quick, short steps where people talk about that they feel like they're a runaway train and they just can't stop their movement. The opposite of that is retropulsion, and that's where individuals take very quick, small steps backwards and without being able to take a big step to stop themselves. Otherwise, they just fall into something or someone has to grab them. And then commonly we see it when someone is walking to a chair and they're trying to make that turn to sit down. So the thought may not be about, how am I taking my steps? I'm taking a good walk. But the thought may be, oh, I've got to get to the chair. I've got to get to the toilet. And the process there to stop the walk and change it into a turn and then change that into a stand to sit really isn't completely there. So those three areas are really the weakness issues, and then how they present. We talked a little bit about that, and we'll talk a little bit about more how this get ready signal, go signal, and no-go signal are impaired and how they do affect not only gait, but also the activities of daily living. And then Heather will talk about how they affect also the speech. I'm going to show you a video here of a client of mine who has given her consent for this video. You're going to notice different areas where she is actually having the difficulty with the freezing. And what will happen is I'm going to talk you through the series of what she is seeing. So let's go back to that video and take a look. So right now we're seeing her with just the freeze with standing up. Not a lot of forward lean, very slow with coming up. And now right now she's having the start hesitation. She's not quite able to take that first step. There's not a lot of weight shifting going on and we're not getting the full foot up. So she's in a freeze right now. She begins to take those slow, small movements. You can see that her arms aren't moving. And then here she begins to change what she's doing. Instead of walking, she's now in a freeze because she's reaching forward for that chair. And you can see she's not close enough to even reach the chair. And now she's going to begin her turn to sit in the chair, but she really isn't properly lined up in front of the chair. So that again changes what she's able to do, and she becomes stuck in another freeze. You'll also see that she's not really looking around. Finally, she turns and kind of sees where the chair is, but now she's stuck in that freeze where she just can't move. And what I always say to people when they're looking at this video now, This is a woman who knew she was being videotaped. It's during the day. She's taking her medication. She has her glasses on and she's wearing her shoes. Think about the difficulty that this could be if this was in the evening, low on medications, not wearing shoes, and the person was thinking about rushing to the bathroom. You can easily see where the difficulty would come in and how falls can so easily occur. So there are different options that are out there for how we are treating freezing of gait. And we have lots of traditional approaches that we've used for a number of years, and you may have used them yourself or seen them in someone's home, where we will put marked lines, maybe perhaps colored electrical tape or duct tape on the floor. Perhaps you've seen the walkers that have the laser beam on them, the red laser beam. Some patients actually have small laser pointers that they'll use. There is the technique of what we call external verbal cueing. And that's where someone else is saying, okay, big step, take a step now. Okay, all right, you need to keep going, keep pushing through, and someone's kind of talking you through it. And then there's the visualization aspect, where you might be completely stuck and you think, okay, I'm going to think about stepping over something to get started. You noticed in the video that I just showed you, my patient was trying to do a little rocking, but it wasn't big enough to really help her get that nice big step. So we know that rocking can be helpful. And then we also have research that points to a different external verbal cue, that being the metronome or actual musical therapy. So people are actually walking to the beat or the time in between the beat of music. Now, all of these things are very applicable and can be used, but what we don't want to do is to have the individual with Parkinson's disease using them too soon. We want to see if we can have a better approach where we can actually train you to make bigger steps and to make more focused, bigger movements when you're walking, so that you don't have to rely on these things, because you may have tape on the floor in your home, but then you go over to a neighbor's house or you go to a wedding, and then those tape lines are no longer there, and now you're in that same situation of freezing. What research is showing us now is that the emerging treatment frameworks on what we as physical and occupational therapists should be doing when we're talking about gait and activities of daily living with freezing is that not only do we have to address both your motor or your movement problems, but we also have to address some of those cognitive deficits, the things that I mentioned before, the difficulty with staying focused or your attention, or difficulty with planning, those problems with executive functioning. And the beauty of both LSVT Big and LSVT Loud is that we work on both of those fronts with the treatment of freezing. So we'll talk a little bit more as the slides go on as to how we employ both of those techniques. So when we're talking about LSVT Big, what is the target of our treatment? What are we really getting at? Our true target is two things. It is hypokinesia, and that means small movements, and bradykinesia, that's slow movements. And because your movements are so small with Parkinson's, they become much more slow. So oftentimes if someone with Parkinson's disease is just simply told to hurry up or you try to rush yourself, it doesn't produce better movement. It actually might make you move into festination or retropulsion. It's only when we really get to that core of those small movements that we increase the speed of the movements. Now, hypokinesia and bradykinesia are both present at the time of the diagnosis with Parkinson's. It's just in varying degrees and how it increases over the length of time. It correlates with the amount of dopamine that you have in your brain. So the longer the time you have with Parkinson's, the less dopamine you have, and then the more likely you are to be suffering with the hypo and bradykinesia. And like I said before, it generalizes across the motor systems. It's not just gait, it's also with speech, and it's also with cognition. There's another term called bradyphrenia, and that means slowness of thought, where it takes you longer to recall information. You might have more difficulty with actually staying organized. So it's almost too much for people to handle with this. So our target of LSVT is attacking that hypokinesia and that bradykinesia. So how do we go about doing that? Well, with the LSVT Big paradigm shifts, we really are using new ways of thinking about rehabilitation. We are thinking about attacking this on three big fronts. No pun intended with the big. Our target is amplitude, and that means the size of the movement. We are going to teach you that you need to move bigger, and that bigger movements are in fact safer and are in fact what you need to be able to stay functionally independent and safe. Then we talk about our mode, and that means that we're working out at a higher level and a higher intensity than you might be used to. So we are really pushing you. We are getting you to do more repetitions of the exercises. We're having you do them over and over again. And we're really working you into real life situations where you're not only just practicing exercises, but you're also practicing these things in everyday life. And then our ultimate goal is calibration. And both myself and Heather will talk a little bit more in depth about this, but we're looking for generalization. We don't want you just to be better at your exercises. We want you to be better at taking a step. We want you to be able to get out of bed in an easier way. So we want these bigger movements and this high effort to generalize into your everyday life of how you're going to be able to move. Now, when we use the LSVT Big technique to treat freezing of gait, the first thing we need to do as therapists is something we call task analysis. We need to unveil or unmask what your freezing triggers are. What is it that you're doing that is setting upon that track for that freeze to occur? So we really look to you, the person with Parkinson's, to explain to us the situations where you freeze. And then we as the therapist need to put you in those situations to see if we can elicit that. So whether that is your start hesitation, whether that is with turning, so turning in place at the counter, turning when you're walking, turning around to sit in a chair. It may be that when you are in an open area, you do well, but then when it becomes more crowded with chairs or furniture or other obstacles, or it becomes more narrow, such as a doorway or a corridor that actually narrows in, maybe that's the thing that is the trigger. We have lots of people who have a lot of difficulty and fear and anxiety with elevators because of feeling rushed, of feeling like people are there. They don't want to slow anyone down. Perhaps they won't make it in when the door closes. And then we also see changes in terrain. If you're walking from carpeting to tiling, or you're moving outside off of the sidewalk and then you have to go onto maybe some grass or a dirt path. And when people are in these situations, obviously in crowded environments and people walking up to them, that can be a distraction if someone is trying to talk to you or ask you some questions while you're walking. Now, oftentimes as a therapist, I see that people will talk to me about where they have the episodes of freezing, but when they come into the clinic, they actually do fairly well. And the spouse or care partner who is with them is sometimes surprised and says, I can't believe they can do that here. They don't do that at home. And that's for a couple of reasons. People tend to perform or want to do better when they're in front of the therapist or the physician. And a lot of times the way that we will help to do this is we'll actually give you a dual cognitive task. So we'll make you do more things at once. So perhaps I have you walking down the hall, turning, and then coming back to go in a chair, but I have you naming all the different kind of cars that you can think of, or as many fruits and vegetables. So I'm going to challenge your brain to a greater level to see if I can bring about that freeze. Because then when I see how it happens, then I can figure out how I can correct it for you. So I want you to take a look at this video, also a former client of mine who's given her consent, and I want you to see she's been asked to walk over to her wheelchair and to have a seat. So what you're seeing here is, again, she's in that complete stop freeze. She's trying to shift her weight. Oh, my apologies. We'll go back to that. She's having that difficulty there. First of all, she's turning far too much of a distance away from the chair to start her backup turn. She's in that freeze. She's trying to unweight her legs. And just every step is really agonizing for her. Very difficult for her to get that actual movement started. And again, I say to you, if this were her trying to get to the bathroom to use the toilet, again, you can see how she might be rushing and even more anxious. So this video is an excellent example of how turning while walking, even with an assisted device, still freezing of gait can manifest itself. And now, unfortunately, she's going to start to turn herself fully around, thinking that maybe she's closer to the chair than she really is. And this could be really problematic if she were to do this on her own and try to sit and the chair wasn't there. So this video actually goes on for well over a minute, but I just wanted to share a portion of this with you to see that. So what is it that we're going to do as therapists? How are we going to use the LSVT Big to help? And we really look at this quote from Benjamin Franklin: an ounce of prevention is worth a pound of cure. So if we can figure out these are the areas where you're having the episodes of freezing of gait, let's look at how you're performing that movement. And if we can get you to move better before that episode, or we can get you to move better throughout what you're doing, then we are very likely to prevent that episode of freezing. Now, if the episode actually happens, then we're going to be able to teach you how to stop it and restart good quality movement to prevent a fall or an injury. And we're really doing that by a very simple mantra, and that is think big. We know that individuals with Parkinson's don't move big enough, and therefore they're moving slower. So let's talk a little bit about how we do that. This is an overview of the full LSVT Big treatment session. You can see on the left side of your screen, we're talking about starting with exercises. We have 7 maximal exercises. Some of them are in seated position and some of them are in standing. Now, all of the exercises can be adapted to a seated position if someone needs to start there and then build their way up to standing. Now, if we look at the first exercise where we're in the standing position, that's actually number 3, the forward step. We teach you how to take this nice big step forward. Now, if we say to you, you know what, remember how you took that big step in the exercise? That's how I want you to take your first big step when you're walking. So we're going to help you to use those exercises and link them back to something that's functional for what you're doing. I'm going to spend the bulk of the rest of my talk on the functional component tasks, big walking, and hierarchy tasks in the next few slides, but that is the second portion of the treatment session where we're getting more into the actual functional components of your movement. So things that you're doing, sit to stand, walking, having any kind of hobbies, being able to go from whatever room to the other room that you want to. So let's talk a little bit more about these in detail. The functional component tasks are 5 tasks. They're 5 everyday tasks that you choose, and they're personalized to you, and you're going to do them 5 times. One of those 5 tasks is always sit to stand, because this is something that even someone who is not walking still has to be able to transfer from a sitting to standing position to get from one surface to another. So we work with you by having you tell us about the things that you're doing and getting to know what an everyday picture of your life is like. So you help us choose those. You tell us what you want to get better on. We see what you're doing. They never change. You're going to repetitively perform that movement over and over again. And it's a very simple movement. And through the simplicity and the bigness, and by practicing it repetitively, we may have you practicing through the course of your treatment sessions 4 times a week for 4 weeks. You may have practiced sit to stand over 300 times. What is it about the functional component task that we want to do? Well, our goal is to hook or cue you into thinking about your big movements and that big effort every day. It's not that I want you to just be really good with your exercises and I want you to think about bigness when you're doing that, but I want you to think about the bigness when you're doing anything. So it may be that one of your functional component tasks is to be able to cross one leg over the other so that you can put your shoes and socks on. So if we do that all the time, every day, and we repeat it with extra big movement and extra big effort, then when you go home, it's going to kind of hook you or cue you to remember, you know what? When I lift that leg up, I've got to do it just like I practice with the therapist. We want you to actually overlearn these simple movements so that, again, you use the big movements and you use the big effort in everything that you're doing, even with things that we may not have necessarily practiced with you. Now, I'm going to talk to you a little bit about some examples of functional components for freezing of gait. So these are some of the common areas that we talked about where people have the freeze. So we may actually have you, if you look at that second bullet, stepping through a doorway. If every time you walk to a certain doorway, you have an episode of freezing of gait, we may have you stand outside that doorway, take a big step through, and come back. Take a big step through, do it again, and we do that 5 times. We may have you doing a big reach and step back to help open a cabinet or to open a door. So again, a simple task, but we do it repetitively, and it's specific to what your need is. Now, this video is going to show you why it's so important to actually turn the correct way, okay? So we're talking about someone who is trying to make what we would call a quarter turn, where someone is moving in 45-degree angles and they might be trying to go all the way around or just turning to the side. And in this video, you're going to see how the feet are frozen, So the individual rotates the upper body, and when the upper body goes one way and the feet are going another way, it can lead to a loss of balance. Luckily, this gentleman is able to catch himself on the chair. So let's take a look at this. So that's why we would do something with your functional component like this 90-degree turn, this what we call a quarter turn, where we would have you, if you were stepping to the right, you would take a big step to the right with your right foot, then with your left foot, and then we'd go back and forth. So there's a reason why we do these functional component tasks for safety. Now, when we're talking about freezing of activities of daily living, again, they're specific to your needs. It may be that you're having difficulty with getting your fork up to your mouth after kind of putting your pants on to the legs to be able to actually lift them back up. It may be buttoning. It may be putting on shoes. Another example for the activities of daily living are people get frozen in bed very frequently, and that could be with all aspects of it, rolling over, scooting, and moving from a lying position to a seated position. And then we talked a little bit before about transfers. So that ability to move from sit to stand, and that could be sit to stand from the toilet, from the car, from your bed, from a chair, from your wheelchair, whatever that is. And then just as much going from standing to actually sitting. And then we move into the component of what we call hierarchy tasks. And those are real world big tasks chosen by you. Those are multiple step tasks. So those are not just a simple task. That's something that has lots of steps to it. So you can take a look at the list here, the examples people have given us. Being able to cook a meal, being able to garden, being able to go shopping, playing with children, grandchildren. Maybe it's doing hobbies. The ability to be able to walk and talk while you go down the hallway of the apartment building where you live. So these are things that have lots of different components of movement in them. So what do we do when we're training you with the hierarchies is we put you again into the situation where you're most likely to freeze, and we break it down into smaller pieces. And over the 4 weeks of treatment, we build it up. So examples for freezing of gait, it could be where someone has difficulty with walking into the bathroom, where they freeze in the doorway, and they also freeze when approaching the toilet. So it may be that the first week we just work on walking through the doorway, walking through the doorway. Then we may add in the next week the walking through the doorway and the turn. As the weeks go on, we take you through the whole movement. And by the end of the 4th week, we're doing the actual task from start to finish. We're talking to you, we're trying to distract you, and we're trying to get you to be able to do it big and safely. Other examples there, walking into a restaurant and even being able to walk to get the mail. Examples of the hierarchy training for freezing with the activities of dailing. So the ability to toilet oneself. So being able to approach the toilet, being able to get up from the toilet, pulling up pants, cleaning oneself, and then again, dressing oneself. Think of all the steps that we do when we're trying to get clothes out of the closet, backing up from the closet, turning, putting the clothes maybe down in the bed, sitting on the bed, pulling up the pants. So again, we start with a simple task, and then we add in more tasks until we're doing the full hierarchy, and we're making it nice and challenging for you so that you can do it safely. So remember my lady before that was making her turn. Here she is with her improved technique of getting to the chair. So you can see she still struggles a bit. We're not at the 4th week. She's not completely independent with it, but she's taking bigger steps. She's getting closer in front of the chair. She's trying to make bigger steps when she's turning. Oh, and I apologize for that. It keeps jumping ahead. So she's in about her 2nd week here of practicing. And you can definitely see how much improvement she has since that last time of asking her to get into her wheelchair. Still not quite able to prevent all of the freezing, but definitely starting to get better. So taking a snapshot in time of her treatment, you can see the difference in what she was able to do much quicker. As I said, the other video was well over a minute, and I believe this one, she was able to do it in about 38 seconds. So the other thing that we're going to work with you obviously is on your gait training. We want you to be able to have endurance so that you keep big posture, big steps, big visual gaze so that you're looking where you're going. We want to work with you in a controlled environment, but then also put you in an unpredictable environment so that we have identified those freezes and those triggers, and then be able to get you to cue yourself and remind yourself how to move big. And then by the end of those 4 weeks, we are adding in all those distractors, the real life environment, we're taking you outside, we're going to the store, whatever we need to do to make you feel safe. Now, that's not to say that everyone is able to do this without an assisted device. In more challenging situations, someone might need the support of a rollator, the U-step walker with the laser, or perhaps the care partner needs to be there to always cue them to make those big movements. So last video here for me. One foot always past the other. In as few steps as possible. Do your turn, 1 foot past the other. That a girl. Good. Now remember, when you get in there, keep going. Everything must be bigger steps. Bigger steps, doing it as few steps as possible. A little bit of a freeze there with the turn. And a plop. Do it again. So we make her do it again. You're going to do it better this time. Stop. Take a deep breath. Stop. Take a breath. Big step to start. Good. All the way down. Make a nice big turn for me. 1 foot past the other. Big turn. That's it. Keep those steps big. Don't think about the chair. Think about big steps. 1 step at a time. You can see where she still has the freezing with the approach to sit. Nope. You want to do it again? Yep. So I take her through that several more times, and we keep practicing it. So it's a lot of repetition. In the beginning, it's a lot of feedback for me as the therapist, but then eventually she's learning how to cue herself. So a few tips before I hand this over to Heather. Remember, big posture is very important. Look ahead when you're walking, not always down at the floor. If you're not taking big enough steps and it doesn't feel too big, then it's not big enough. You have to focus your attention on what you're doing. You have to think big, and we must plan ahead. So give yourself the time you need. Make sure you're rested. Make sure you're taking your medications on schedule. And remember the 4 S's of breaking a freeze. You saw me in the video say to my clients, stop, stand big, shift your weight big, and step big. When someone continually tries to push and rush like she was doing with her turn, chances are she's not going to get anywhere, and she's going to end up in a festination, and then maybe will fall. So remember that calibration is the heart of the matter. Heather will talk a little bit more about this, but the truth is that people with Parkinson's need to make bigger movements with more effort to make normal quality movements. Heather will talk a little bit more about these, but what gives us the difficulty is that you're not sensing that your movements are too small. You actually think that bigger movements feel too big when they're really normal. So you have difficulty with feeling what you're doing. And then you may also have difficulty with staying focused on what you're doing. And that's where we will spend the time with the repetitive nature of the practice of this. So remember that we need to help you recognize the need to use those larger movements. We're going to show you that those bigger movements are really normal and that they have a positive impact on your function. And we want to assure you and make you feel comfortable with using your bigger movements in the real world. And then we repeat and we repeat and we repeat. So we want you to walk through the door where you are retrained with your calibration, you're learning how to internally cue yourself, and that normal movement and effort, you're getting that by doing your bigger movements, and you have learned how to be safer. So our goal is that you will use your bigger movements automatically, and that you will have long-term carryover of this use, and that you will be able to stay as functional and as safe as possible. So now I'm going to hand over the second half to my colleague Heather Hodges, and she'll talk about the speech characteristics and the treatment using LSVT Loud.
Great. Thank you so much, Heather. That was very informative, and I'll be talking to a lot of the points that Heather brought up as well, and how LSVT Loud addresses some of those same sensory, motor, neuropsychological, and calibration issues. When we think about the speech characteristics in Parkinson's disease, we see that the voice is often reduced in loudness. The voice has become quiet or perhaps even very quiet. A hoarse vocal quality where a patient may have more of a voice sounding like this. as well as a monotone or mono pitch where there's not much inflection and instead they sound more one note all the time. Imprecise articulation, or people complaining that they feel their speech is slurred. There may also be a vocal tremor present with those with Parkinson's disease. And we see also hesitations in speech, which speaks to some of the freezing that occurs with those who have Parkinson's. Along with that freezing of speech, we can also see that signal that Heather mentioned, where it's the turn off or the stop moving signal gets a bit frozen. And so patients will rush on in very fast amounts of speech going very quickly, and their rate all of a sudden is very fast, something like that. Now, going back to the hesitations, we see where perhaps a patient maybe asks something like, "What would you like for dinner?" And there's a hesitation there. It's not just that the patient is really closely thinking about what they are craving that day or what they'd like for dinner. And the caregiver or family member may say that they end up repeating themselves because they didn't think that their family member heard them the first time. And this creates frustration where the family member or caregiver is repeating themselves frequently, and the person with Parkinson's feels that they're being interrupted, and then they have to start the process back over again. So that's one of the ways that manifests with hesitations of speech. Interestingly, and documented in the research, some patients report that decreased volume, hoarse voice, or monotone voice was their first symptom of Parkinson's disease. Next slide, please. So when we're using LSVT Loud to treat the freezing issues, much as Heather mentioned for LSVT Big, we want to unveil what triggers a freeze during communication. And so this allows clinicians to tailor their treatment to each patient. This allows the clinicians to guide their treatment planning. So they'll ask, do you freeze when you talk on the phone? Do you freeze when you order at a restaurant? These very specific questions. So we see that there's that start hesitation that I mentioned, the example with asking what someone would like for dinner. Some people also report that if they have to speak in front of the group, such as at their Parkinson's support group, or maybe if they're making presentations at work still. Distractions, perhaps one-on-one in the treatment session with me, they may not be distracted. They're in a small room, it's a quiet environment, there's not much to distract them, and so they may not have as much freezing in the clinic room. And if I don't ask those patients these very specific questions about, do you freeze when, fill in the blank, I may not get a good feel for that, and then I don't target it in therapy where that is absolutely vital to treating this population. Dual tasking. If someone is multitasking, they have more difficulty perhaps. Speaking for long durations or more complex sentences, compound sentences, run-on sentences. Crowded environments or loud environments, we see this a lot occurring with restaurants or eating at a dining hall. And speaking on the phone often is a difficult environment to speak on, and there can be increased freezing, which is difficult when you're not talking face to face with someone and can lead to more interruptions, which then makes communicating even more frustrating, and it becomes this vicious circle. Next slide. So what we do in LSVT Loud is increase amplitude. Just as LSVT Big increases the amplitude of movement, having patients move their limbs bigger, we have our patients move their voices bigger, move their vocal cords bigger, and their articulators bigger. And they all do this under the umbrella of Think Loud. Over the treatment course, we get this to be more and more frequent so that the frequency of freezing or the likelihood that freezing will occur decreases over time. A general breakdown of a treatment session includes daily exercises, getting in and getting a good workout of the voice system. So we do sustained ahs, it's just an ah, and we're building up respiratory and vocal coordination. We're also taxing that motor system. We work on pitch since many patients are monotone, so we do highs and lows, ah, or oh. And these are practiced multiple times in a session. It really does become a workout, where a lot of people may not think that speech therapy can be exercise. We really get in, and through multiple repetitions, we're driving motor practice, we're driving sensory recalibration so that this voice that feels too loud but is actually very normal sounding becomes more and more automatic for the patient. And then we do functional phrases. This is getting into things that a patient would say each and every day, multiple times a day, and we practice those even further in the therapy session while using Loud. I'll get into more details about those. I'll also get into more details coming up about the hierarchy, where over time, in the second half of every session, we train amplitude that we took from these core daily exercises, and we put it into context-specific and variable speaking activities. And we increase that complexity over time, where in week 1, the hierarchy tasks consist of word and phrase level material. And then as the weeks go on, those reading materials or those materials for call and response if someone has a hard time reading or vision difficulties, they start getting longer and longer, from sentences to reading paragraphs. And then week 4 is where we really put the rubber to the road, because our end goal is that patients will use a louder voice whenever they speak. And so week 4 really focuses all on conversation. And every day of the month of therapy that patients are with us, whether it's a weekend or a holiday or their day off from therapy, they're doing homework and carryover exercises. They also do homework and carryover exercises during a treatment day as well, outside of the therapy room when they're at home. But they get a lot of practice every day with LSVT Loud. Next slide. So getting into more detail about those functional phrases, the goal of these, much like the functional movements and tasks that Heather mentioned, the goal of these is to hook or cue our patients into thinking about their loud voice and effort in their everyday living. You will have to practice these everyday phrases so many times, it ends up being 50 times a day, that every time you go to say one of those phrases outside of the therapy room, your new technique for loudness will be automatic. And this helps you to remember to think loud throughout your day. And because it becomes so overlearned, these functional phrases serve as a great practice tool to overcome speech hesitations and to give our patients frequent opportunities to feel successful every day. Next slide. And how we come up with these is they are patient-driven. The clinician won't just come up with your phrases, things they want you to say every day. We really want it to be coming from your everyday experiences. So we ask, what's something you say every day? Perhaps it's, hello, this is Jim. That's the way that you answer the phone. Or you see your neighbor every day and you ask, how are you today? These are things that we want you really saying in your normal environment every day so that they mean something to you, and also so that they are so frequently practiced that when you go to say, how are you today to your neighbor, it just comes out loud whether you were thinking about it or not. Some examples too. With this and getting so much practice of saying your functional phrases is that when you see that neighbor, you're much less likely to hesitate and ask, how are you today? more automatically without that hesitation, because you are driving your speech system and overlearning this cue every day of treatment and every day outside of treatment with homework too. Over time, we'll also gradually add in distractors. So real life activities where perhaps you are sorting cards while saying your phrases, or maybe you're digging through your purse as you ask your neighbor, "How are you today?" We know that multitasking or distractor tasks can lead to more freezing in movement and in speech. So once you start getting proficient at just saying the phrases more automatically in your loud voice in the therapy session, we want to continue to push the envelope. So we'll add in distractor tasks or dual task challenges like sorting cards or picking up the dog bowl and pouring in the food while saying phrases. Some of my patients who had engineering backgrounds or worked in engineering, I'd have them solve math problems while they were saying their phrases, something that was very realistic to their lives, so that it applied to their speaking environments outside of my therapy room. Next slide. The hierarchy tasks are also individualized. These are the second half of therapy, of each therapy session, and they are identified through discussions on what your interests are, hobbies, typical communication situations. We'll also ask about when you're having difficulty communicating. If it is over the phone, then some of our practice during the hierarchy activities will be to talk on the phone. We'll ask about when you are freezing. We want these exercises to be really salient, to have something that's meaningful to you. We know through research that if we do meaningful things in therapy, that it actually improves neuroplasticity and helps drive this idea that perhaps we're changing the disease course. So we want to make sure that they are important and meaningful to you. We also may add in some external cues. If people are having a difficult time initiating their speech, sometimes we add an alphabet board. We'll actually see an example of this in a video later. But what that is just a piece of paper with all the letters of the alphabet marked on it, and a patient would point to each letter that started a word of their phrase. So if it was "How are you?" they would point to the H as they say how, the A as they say are, and the Y as they say you. And we see that sometimes that external cue can help to trigger the vocalization so that the hesitation isn't occurring. Over time, if we do have to bring those in, we start to extinguish or take away those cues over time. Because we know that you don't necessarily have an alphabet board at your disposal everywhere that you go. So we want to make it realistic. But sometimes we need that in the beginning. And same thing as I mentioned with the functional phrases, we'll gradually add in distractors, real environment and dual task challenges, such as walking my patient down to the cafeteria and ordering a coffee, talking and walking around the department as we do our therapy session. Next slide. So here are some specific examples. If the freezing trigger for one of my patients is that they freeze or hesitate when answering the telephone, a target in the hierarchy is: use your loud voice with greater effort when using the phone. Let's practice. And we would grab that cell phone, perhaps call a retailer or the pharmacist where they want to check on their prescription, or their family member, and they would think loud as they go to answer the phone. If they note that they freeze when they're trying to speak in a loud restaurant, we would ask them to use greater loud voice and effort over background noise. If a client is freezing when trying to speak for longer than a few minutes, sometimes that's when things get tired and fatigued and it's more effortful. That would be something we'd systematically work on over time. In more severe cases, we may need some additional support of family members for cueing. Just as with other cues like the alphabet board that I mentioned, we try to extinguish those cues from the family members as quickly as possible too, but knowing that in some more severe cases, it does serve a good purpose to have the family member trained and they continue to cue to some degree. What I'd like to show next is a video example of a more severe festination of speech called palilalia. This gentleman enrolled in our study and completed the first 2 weeks of therapy. He did well when the therapy tasks were just word or phrase level responses, but when we got to longer readings, longer conversation, that festination of speech where you get stuck on a sound and the brain and the articulators won't advance to the next sound was just getting to be too much in the way. And so we brought in an alphabet board. You'll see that the board comprises of the alphabet and the patient is just simply pointing to each letter of the word. Along with increased loudness, it helped this patient to further slow down that festination because his stop cue was frozen so that he didn't get stuck on repeating those sounds over and over. So we'll watch that video now. And I can't tell on my end if the sound is coming through or not. There we go. So he's unintelligible. You really can't understand him.
We have one more session tomorrow. Yes. Tell me what you've learned from the therapy that you've done.
This was after he introduced the board.
And talk slowly.
Uh-huh.
Use this board.
Okay. I want you to say that again using the board.
I learned to use this board to slow myself down.
Good. Okay. What about today, after you leave here?
Shopping.
Shopping. Tell me where you're going and what you're going to buy.
Food.
Give me a whole sentence without the board. I know it may not come out well, but it's for the camera.
Food shopping.
Okay. Now with the board.
We are going food shopping. Good night. How are you?
Nice.
Well, I'm fine, thank you. Who's there? Let's go for a walk.
Nice.
What's for dinner?
Good. Try that one again with the board.
What's for dinner?
Good job.
That was a good meal.
Try that one again.
That was a good meal.
Good. See, you didn't need me to tell you that.
I'm tired. It's been a long day.
So at the beginning of therapy, when you see him initially in the booth, he was talking about the happiest day of his life. And so something very meaningful to him, but you couldn't understand a word of what he was saying. At the end of therapy, he had the board, but you may have noticed that he didn't have to use the board 100% of the time to be intelligible. It's a nice example of eliminating those outside cues as soon as possible so that all the patient has to think about at the end of therapy is loud. They only have to think that one thought. When we get into freezing with communication, we also look at carryover activities. I want my patients to be successful in the therapy room, but I also, even more importantly, want to give them an opportunity to practice outside of my therapy room. So we'll come up with activities that the patient will be doing during the day. We'll make it specific to freezing situations. So if a patient tells me they're hard to get started talking in background noise, and they're going to a restaurant later that day, we'll practice specifically things they want to say at that meal, whether it's greeting their friends or talking to them about progress they're making, fundraising, or whatnot. The complexity of the carryover activity will match the level of the hierarchy. So in my first week of therapy, I would expect them to have loud word and short phrase vocal productions. At the end of therapy, we would be more assigning whole conversations for them to stay loud. And here's some examples: ordering meals at a loud restaurant, calling customer service to discuss a recent purchase that they had, or some people who are presenting at work or to a support group, we would practice that perhaps in week number 4 of therapy. The progression of treatment for freezing using LSVT Loud over the 4 weeks would look something like this. In weeks 1 and 2, we may need more caregiver reminders, cueing and pre-cueing to the patient. I want you to think loud and tell me, what do you want for dinner? Putting up signs in key areas of the home that maybe they do more speaking. The clinician may consider an alphabet board or a metronome like we did with the gentleman I showed you, but again, we would drop that external resource as soon as possible. In week number 1 and 2, repetition is very key, and we always keep it simple. If I'm trying to change an element of my behavior, if I have just one thing to think about, I'm much more likely to do that than if I have 5 different things that I'm trying to think of all at once. And the same is true for our patients, especially when there may be some more subtle neuropsychological changes happening. So your clinician will tailor your carryover activities so that they instill the confidence that power over freezing is possible. In weeks 3 and 4, the clinician will add dual tasks or distractor tasks, real-world situations when training, functional phrases, the hierarchy, and the carryover activities, those assignments. By the end of week 4, you should be able to do and complete the whole triggering task without freezing in real life consistently. We also, in the later weeks of treatment, like to train during times that your medication may have worn off. So we challenge the system that way as well. The tips from the experts: loud voice. If it doesn't feel too loud, it's not loud enough. And I want to just reemphasize that loud is what the patient feels inside. But rest assured, we're not actually training you to go out and shout at people or be inappropriately loud. But because of the sensory calibration and motor issues, loudness is a feeling. And we have patients just focus on one thing. Think loud, think loud, think loud. We keep it simple. And as Heather mentioned, planning ahead. If you need extra time, if you can time things where your medication schedule is optimized and when you're well rested, those things certainly help as well for speaking. And remember, with loudness as well, calibration is at the heart of the matter. Some barriers that can occur to successful calibration is the sensory issue. People with Parkinson's disease don't perceive that their voice is too soft, and when we get their speech to a normal loudness, they feel like they are being way too loud. It feels like this, when in fact it's actually coming out totally normal like this. Internal cueing. People with Parkinson's have been demonstrated to have difficulty remembering to use their louder voice. It requires a lot of repetition before patients can self-cue. That's why therapy is intensive. That's why homework and carryover activities are intensive. We need a lot of repetition and practice. Sometimes, too, there's neuropsychological deficits, staying focused on using loud and dual tasking. That's why we address that in therapy by adding in those cognitive tasks. What we want is learning. We want a patient so calibrated that the voice you see to the left of your screen, nice and strong coming out, when a patient walks out the therapy door and they're in the parking lot or they're at home, that they've learned this new loud and they are performing it and have learned it in their everyday lives outside of the therapy room. Our goal at the end of treatment is that people with Parkinson's disease will use their louder voice automatically in everyday living, and that there will be long-term carryover of increased amplitude use. Our research over the years has shown that these therapy gains can last at least 2 years after treatment, if not more. In order to successfully reduce freezing issues in those with Parkinson's disease, we must understand each individual's specific triggers, tailor LSVT Big and LSVT Loud treatment to address that patient's specific freezing. We must achieve calibration. It requires more time, effort, and possible caregiver involvement in those with severe freezing issues. And we're also treating freezing issues with LSVT Big and LSVT Loud so that we improve the quality of life. We improve independence with activities of daily living and mobility so that we can reduce falls. Now, how to find a clinician. You can contact LSVT Global via phone, email, or website. This is a screenshot from our website. You'll notice that in the top left corner, right under where it says LSVT Global in the dark blue line, that there is a link for Find a Clinician. When you click on that, you would simply type in some of your geographical information. We find that zip code tends to reveal the most results, so I would suggest doing that. And when you type in that area, your area or zip code, you would get a list of clinicians who are certified. This is a specialized therapy that physical therapists, occupational therapists, and speech-language pathologists have to go through. So not all therapists do these two therapies. And from there, you can find LSVT Big and LSVT Loud clinicians to reach out to. Other steps to getting started. Asking your physician for a referral and a prescription for speech or physical and occupational therapy for evaluation and treatment. You can visit our website, lsvtglobal.com, as I mentioned, to find a certified clinician. There's also DVDs that are available to introduce movement exercises in LSVT Big and voice exercises in LSVT Loud, and there's some links to those. And we like to sum it up with this wonderful quote from a patient who went through LSVT Big and LSVT Loud. She was a graduate of both. She said, it is possible to take charge of your life, even with Parkinson's. It is possible for your will to override your brain. It is possible to have power over Parkinson's, which is pretty powerful. And I know that we've gone over our allotted time. We had a lot of great information to share with you, so I really appreciate how many folks were able to stick around and go over the hour time frame. We'll have a couple of minutes to take questions. If you think of a question later, you can always email or go to the website. There's the contact information on this slide. So if questions do arise, our office and our specialized clinicians are happy to help you.
Thank you so much, Heather. Excellent information on LSVT Loud. We do have one question here that says, can I get this whole presentation repeated later? And the answer is yes. We record these presentations and they are on our website available for you to listen to and view again. The next question, actually the next two questions now, Heather, are for you. And the first one here is, when I want to tell someone something, I've noticed that I have trouble recalling a common word or someone's name as part of my story. Is this part of Parkinson's? And if so, how do we work on that?
That's a great question, and something we definitely do hear from our patients, that they notice that happening more frequently. It can be a part of the Parkinson's, where we call it word retrieval, where you know the word, it's in there, it's just not quite coming out. And sometimes we see that through working on the voice and getting that louder voice that's easy to understand, helps to stimulate the whole system, from breathing to vocal cords to recall for words. So indirectly, we see that LSVT Loud can absolutely help that. And that would be something I would recommend to get evaluated from a speech-language pathologist, because it is something that can also occur separately. It can occur without Parkinson's or alongside Parkinson's disease. And so by getting that evaluated, the therapist would have insights into whether that's really something that should be specifically targeted in therapy, or whether they think that once the speech and voice system is stabilized through LSVT Loud, that would improve over time. So it's definitely worth getting a specialized referral from your doctor to be evaluated for LSVT Loud, as well as word retrieval issues.
Great. Thank you so much, Heather. I'm going to take the next question. It says, if a patient is experiencing freezing but still thinks it's okay to drive, how do you have this talk? And this is a fantastic question, something we are asked quite frequently. Safety is first and foremost, not only for the individual with Parkinson's disease, but for others on the road. And when this is a question as to whether someone is safe enough to drive, that needs to be taken up with the physician. And we always recommend that someone is actually tested. There are physical and occupational therapists who are car and transportation evaluation specialists. And you could talk to your physician about getting a prescription for one of those specialized evaluations. It is nothing that is to be embarrassed about. It is mostly to keep people safe and to keep people comfortable. If this person is driving in the car and anyone says to this person, you know, I don't feel comfortable or I feel nervous, that is usually the first sign that something is going on. So please do bring that up with the physician and then start that conversation going as soon as possible. And Heather, I'm going to give you one more question before we wrap up here. It says, I found that singing karaoke at home has been a fun exercise and that it might help others. What are your thoughts on this?
I think that's great, and what a fun observation. You know, we say that with most things movement related, and we certainly see it with voice as well, that the more you use it, the more it can improve. And the less you use it, the more you lose it. We do see that some, even like Parkinson's support groups, will have singing groups to help encourage people in a fun way to keep their voices moving. We also, though, have been studying brain image data on LSVT Loud, and this is true in other areas of voice and speech therapy. And we know that neurologically, singing and talking are two separate things that the brain seems to see as distinct. So while we see that it absolutely helps the motor system and extra practice is good, it may not necessarily work on those sensory issues, those ideas that when you talk at what feels like a normal loudness, it's actually coming out too soft, and when you go to talk normally, it feels like you're inappropriately loud. So for my patients, I do recommend that if they are in a singing group or if their Parkinson's support group does singing, to keep doing that, but I wouldn't say it's a replacement for LSVT Loud. We really are driving a specific behavior within the motor speech system that neurologically is separate from singing. And so I'd say keep doing what you're doing. It's good practice. It helps the motor part, but it might not help the sensory issues and some of the more neuroplasticity that we're focused in on with trying to pause or slow down the progression of the Parkinson's disease as it affects your voice.
Great. Thank you so much, Heather. And remember, everyone, this webinar will be available online for you to view at a later time. We thank you so much for spending time with us today. We do know that there are some people who still have some questions, but unfortunately, we're going to need to wrap up now. So I'm going to ask those few people who still have questions logged in to go ahead and shoot us out an email at info@lsvtglobal.com, and we will be happy to answer your questions. Again, we thank you for your time and look forward to working with you in the future. Goodbye, everyone.